Hello and welcome, everyone. I'm Janelle. I'm so excited to be your host today on behalf of the amazing team at MaxGen Labs, where we're all about empowering your wellness journey through personalized testing. Whether you're a practitioner or just someone simply passionate about hormone health and functional medicine, you're in the right place. We've got a powerful and eye-opening conversation ahead. Today, we are thrilled to be joined by our current practitioner of the month, Dr. Tara Scott, known as the Hormone Guru. She is a nationally recognized speaker and the founder of Revitalize Medical Group with over 25 years of experience helping people uncover the root causes of hormone imbalances. Dr. Scott is a certified OBGYN, functional medicine, integrative medicine, and anti-aging regenerative medicine. Through her clinical work and educational platform, she's helping bridge the gap between conventional and functional approaches to health. Today, she'll be unpacking the real science behind hormones, what's fact, what's fiction, and what you really need to know to support your body through every stage of life. And yes, we'll be saving time for your questions at the end, so be sure to drop them in the Q&A. So without further ado, let's give a warm welcome to Tara Scott.
Well, thank you, Janelle, and thank you to the MaxGen team for allowing me to speak. I've been talking to Dr. Yarbrough for a while about wanting a better hormone panel. So I'm super excited. Let me get my slides up here to talk to you guys today about just maybe more like what I think are important for genomics. So just to get to know each other, type in the chat. I know a lot of people probably listen to this after the fact. So for those of you that are on, let me know where you're from, where you're listening from, and also let me know what your discipline is. Are you a naturopathic doctor? Are you a chiropractor? Are you an MD? Are you a health coach? Let me know where you're listening from, just so we can get to know kind of what the audience is and what your background is. So no matter what discipline you are, a lot of people are now able to order and interpret and use the information we get from genomics, and it's really helpful from a preventative standpoint. So I always kind of backtrack and have to take a second to talk a little bit about hormones and why I think they're important. And I promise I won't go super deep in the biochemistry. But when we think of hormones, we're taught about the menstrual cycle. And yes, this is aimed at reproduction, but women we know are much more than reproduction. And we know these hormones do much more than just reproduce. But the important part is we have estrogen in the beginning half of our cycle that is made in the follicular phase. We get a signal from the brain to say, hey, egg, it's time to grow. In the middle of the cycle, we have ovulation, and then the shell of the egg produces progesterone. So the balance of these two hormones is really important. And so not only does it depend on your body and how much you make, it depends on your gut, it depends on your liver, and it depends on your genomics. So why is it important? Because we think that estrogen and these hormones, a lot of people think they're terrible. So what was the issue? Why do they cause cancer or disease or side effects in some and not in others? Well, I always use this example when I'm talking to my patients. Suppose I tell all my patients to drink 2 liters of water, and that is my health recommendation. And I say, in order to be properly hydrated, you should drink 2 liters of water a day. Well, what if you're a marathon runner and it's 80 degrees and you only drink 2 liters of water? Following my advice could cause you to be dehydrated, right? And so what if you are a person on dialysis and you drink 2 liters of water? Following my advice, you could get heart failure. So does that mean water is dangerous and no one should ever drink water? No, it means the patient and how they get rid of estrogen or water and what their clinical scenario is. So that's part of this confusion that we have with hormones, is that one dose isn't the same in everybody. One person may be making a different amount. So genomics are a key factor for us to understand estrogen metabolism. So why is it important to know about estrogen metabolism? Well, because how can we really have a randomized placebo-controlled trial in any of these people? Everybody has ovaries or no ovaries. They have endogenous hormones. They have peripheral conversion. They have gut different detoxification. And so I have found, looking at a combination of estrogen metabolism with the genomics, of a patient to be extremely important, not only for prescribing, but understand the person's endogenous hormones and what it is helping them with. All right, so this is a very busy slide, a stereogenic cascade, but my point being is that all of these enzymes are going to be genetically coded, and we do have information on some of them, not all of them. We know that they can have single nucleotide polymorphisms. That means just one little nucleotide can be abnormal, can be different, can have a mutation, so that affects the activity of these enzymes. And so if we think about, all of these enzymes being able to be augmented, meaning sped up or slowed down, that is certainly going to happen. And this sort of, if we talk about your commute, how long is it going to take you to go in a highway from one place to another? Well, it's going to depend on a lot of things. Time of day, it's going to depend on, is there construction and is there snow if you live in the north where I do. So all of those things are really important, and that's where genomics comes into play from a hormonal standpoint. This is another reason we look at hormones, is because every receptor, every cell has an alpha and a beta receptor, and all of the types of hormones are not the same. We have estriol, estradiol, and estrone, and they all work at the receptor differently. Now, the alpha receptor wants to grow, and the beta receptor wants to kind of have put on the brakes. So that also gets into risk. So we need to assess for every patient, I believe, their detoxification. And that involves two things. One, it involves metabolites, and two, it involves genomics. So ideally, we'd want to know patients' genomics. Now, the industry has come a long way with pharmacogenomics. That is aimed at how will this drug affect you? And it's aimed at, if I put you on this medication for depression, for anxiety, is this a good fit for you? So that's pharmacogenomics. What does the body do to the drug? But I also think it's important to look at detoxification. So when we're looking at detoxification, we've got toxins that come in the liver. Phase 1 is cytochromes. Phase 2, depending on what it is, it could be sulfation, it could be glucuronidation, it could be methylation. And then it's turned into another metabolite. It's labeled as waste. Well, it goes either to be peed out or it goes to the gallbladder into the bile to be pooped out. So that's how we get rid of toxins. So what we know is that you have something here in the first phase, that's a set of enzymes, and then it's turned into intermediate metabolite. That intermediate metabolite can be more toxic if it stops there and you don't finish the process to get to the water-soluble molecule. So that's why we see harm with estrogen. All right, estrogen metabolism. This is what it looks like. It's very complicated. You can't really, I guess, because this is a dark slide, you can't see that these three enzymes are different. And these are different enzymes, and these are different enzymes. So if you go down the wrong pathway, you're going to experience DNA damage. And that's where we get in trouble with the different types of cancer, and maybe even not cancer. Maybe we're talking about endometriosis or fibroids or something like that. Okay, so it's really more important for us to increase the 2-hydroxy pathway, which is one of the options of estrogen metabolism in the first phase, than it is to reduce the 4-hydroxy pathway. Now, knowing how these are genetically coded is also very helpful, but that's not the only piece we need to know, because not only the genomics, but we can influence them with epigenetics. Well, how can we increase A1, CYP1A? Well, we can give DIM. How can we increase COMT? We can give B vitamins or magnesium. How can we increase quinone reductase or glutathione? Well, we know we can do things if we know their genomics. So again, it's just a piece of the puzzle. Now, it's harder actually to reduce CYP1Me1. It's easier to decrease glucuronidase, which is in the gut. And so knowing these enzymes and how they're genetically coded is really important. All right, so if I break down further the detoxification, when I explain it to my patients, I say phase 1 is like you're sweeping your floor. That's the first process. You're sweeping your floor, you're getting all the crumbs, and you're putting them in the dustpan. Phase one is cytochrome P450 in the liver. It's broken down to three pathways, 1A1, 3A4, and 1B1. And 1A1 is almost always depicted as green because it's a good metabolite. 3A4 used to be red, but because there was a thought that it was maybe harmful, but now it's blue or yellow, depending on what test you're looking at. And then 1B1 is more the harmful pathway. We don't really want things to get stuck there. So that's why it's usually labeled in red. Okay, so the second phase after you sweep your floor, so we have estrone and estradiol. They're coming to, we have found that these metabolites, this is 1A1, is less carcinogenic, and the 1B1 going to the 4-hydroxy is more carcinogenic, so more causing cancer. That's why we care. So how do we support phase one? Well, we look at iron, we look at cruciferous vegetables, as I said, and DIM and I3C and quercetin. So if we know how those phases are working, we can help our patients detoxify. Phase two is like you're going to mop the floor next. Okay, so you've swept it, now you're going to mop it. So this is generally for estrogen methylation, which involves the enzyme COMT. There's also an enzyme 17 beta HSD, and that goes after the 3A4, the 16 hydroxy, 2 estriol. So the third phase is the gut. Think of it as the Roomba coming along behind, making sure you didn't lose any crumbs. And so once the liver goes through it, it's going to go into the gut. So you have to have a healthy gut flora. And if you have too much beta glucuronidase and you don't have the right amount of glutathione, those are things that are going to also impair detoxification. Okay, so methylation is a very busy slide. You may have heard people come in and say, I've got the effer gene, which I don't know if I can say that, MTHFR gene, and I have this. Well, that is only one tiny little enzyme of this whole big chemical process. We've got the methionine cycle, which has to do with homocysteine. Elevated homocysteine increases your risk of heart disease. So we look at that in our patients, menopausal or perimenopausal. We've got SAMe as a methyl donor. So these enzymes, some of these are on, we'll see on the MaxGen new report. We've got the folate cycle. So this is important pre-pregnancy for neural tube defects, also has to do with cardiovascular outcomes. Now remember with genomics, it's really hard to distinguish causation and correlation. So we can't really say it causes this, but we know that they're involved. After this neurotransmitter cycle, gosh, a lot of my patients are having mental health issues because they're genomics. So this is another place where I find it extremely helpful to know genomics. And if you'll notice here, this COMT is very important as far as neurotransmitters, but it's also the second phase of estrogen detoxification. And then we've got your serotonin over here, and we've got nitric oxide, which is important not only for erections in men and cardiovascular, but for women and vaginal discharge, you need nitric oxide. So this is a very busy slide, but a lot of these enzymes are on the report. All right, so this is kind of a snapshot of the works report, some of the enzymes that I like to look at. You've got your MTHFR. They give you, this is an allele, so it would be 677. And when we see heterozygote, we know that you have a wild type would be more common, like the normal population. Heterozygote would be one abnormal. You may know all this already. And then homozygote would be maybe a much more slower production of that enzyme and a possible risk. So we looked at some of these MTR, MTRR, MTHFR, MTFHD, MAT. So if I just go back to here, here's MAT. We have SHMT, but MTF1 is up here, BHMT. So some of these enzymes here, and then here's your COMT, are involved in that. So this will tell you the RS number. It's like the address numbers of the house. So if you want to know a specific address, you can look at it, and this will tell you whether there's a variant form. And for example, here, heterozygote mild methylfolate deficiency and homocysteine. So now you'll know, let's check homocysteine on this patient, right? And this is maybe a very mild reduction, mild decrease, no variant found, and then homozygote methylation. And so we know for MTHFR, maybe they need more B12. Maybe you should be checking their B12. So this is part of the works report. Okay, so the ones that I see that are really important for hormones, one of them is this MTHFR. Now, it was more when I was delivering babies, it was more as far as neural tube defects. And so this is one of the reasons we want to make sure that prenatal vitamins have folate, but it's also associated with heart risk, heart disease risk. So we check that as far as menopause in women. So this is what your report looks like. You've got your, first of all, some people can't use folic acid. They've got to turn it into folate. So that's also important. So you've got your digestion SNP, full H1, RFC, DHFR. This is important, this MTHFD1, because tetrahydrofolate has to get in to make 5,10 methylene tetrahydrofolate. And then it gets to MTHFR. And so you have all these other things that have to do with methylation. You can see here in this report here, what are the foods that are going to help you? That's why I kind of love this new report. And secondly, what are the associated symptoms and conditions? So we talked about anxiety, we talked about depression. Well, I guess I didn't talk about migraines, but I see that. I see this with breast cancer also, and heart disease. So I think this is really important, not just for hormones, really for wellness and longevity when it comes to heart disease, and especially for mental health. This is what you'll see on the report too. This is the patient facing report. So you may be sensitive to methylfolate. So it tells you, gives you some recommendations, methyl donors if you're going to be sensitive, folate and compounding genes, RBC folate, and then some labs. So this is the text that you'll get that's generated based on your patients, in this particular patient, the heterozygote findings. All right. The next thing that I think is really important for my patients is phase 1 SNPs. And so as I mentioned, we've got 1A1, 3A4, and 1B1. So it's really important because these three metabolites do have different affinities to the receptor. So when there is an issue with 1A1, when there is an alteration or a SNP, it's usually an upregulation, which means it wants to go preferentially down that pathway, which isn't a problem for 1A1 because that's a good metabolite. When we talk about 1B1 though, that's a little bit of a problem because that's that red pathway. And if you couple a 1B1 with a slow COMT, you're going to get a bottleneck here. And data has shown that an increase of this particular metabolite has been associated with an increased risk of breast cancer. And when they run these tests on patients who already have breast cancer, they have seen higher percentages of the 4-hydroxyestrone metabolites. So these are the metabolites that you would see, and we'll go over this in a urinary metabolite testing. Okay, 3A4 is the third pathway option in phase 1. But of note, a lot of other traditional pharmaceuticals and drugs are metabolized with this cytochrome. So if you have that patient that's sensitive to anything and they take a tiny bit of one medication and have an exaggerated response, sometimes it's a 3A4. Now, think about this. If they have a fast, things are going to work quickly, okay? And if we go back to the 1A1, that's also the same 1A1 and 1A2 with caffeine. If you work fast and you drink caffeine, you metabolize it quickly. You could have coffee at 10 p.m. and go to bed. Now, two of the people in my family, that's what they have. The other three of us, when we drink coffee, it keeps us up and it's wired. We have slower 1A1. So that has to do with metabolism. So the 1B1, you don't want to see a SNP of that with a COMT SNP. So this is what it looks like on the report. We've got that. So you see the caffeine metabolism here. We've got the slower form of 1A1, no variant form, wild type. We've got the 1B1, elevated 4-hydroxy, okay? Sometimes people with slow COMT compounds the risk, so that's what we see here. So phase 2 then is usually catecholamine O-methyltransferase. And so there's several of the alleles that we know that are important. This study showed that reduced COMT activity is associated with higher dopamine and norepinephrine, lower pain tolerance. And so we see that these are V158M, H62H, and L136. So this particular person is homozygote for, this is the one we have the most data on. So we say that if you're a slow COMT, you're a worrier. And if you're a fast COMT, you're a warrior. So slow COMT would have increased dopamine, increased catecholamines, and what's usually called MET is also slow, backup of estrogen. Now, these are the other intermediate activity. So they're going to affect your dopamine and your norepinephrine and your estrogen. So this is where we see COMT here, okay, on both of these. And so we can see a backup. What are the other important hormone SNPs? So this is the other one that I'm so excited that is on this report. I've been bugging Dr. Yarbrough about this. CYP19, aromatase. Now, keep in mind, this enzyme is highly inducible. What does that mean? That means that so many of the things that are not genomics can affect it. And this is kind of cut off, but metformin can make it slower, ketoconazole, chrysin, and anastrozole, vitamin C. And what can make it faster? Excess fat, alcohol, zinc, stress. So we as women don't want a fast aromatase, right? Because if you have an aromatase SNP, you're going to dump your testosterone into estrogen. You might not see it in any serum testing because this is happening in the periphery. We don't want it to happen for breast cancer. And if you take testosterone, a lot of times people aren't monitoring this. Is it turning into dihydrotestosterone or is it turning into estradiol? So I think this enzyme is very, very important. If it's fast, it's going to make estrogen dominance worse. Now, 2D6 also new on the report, so super excited about this. This is the enzyme that has to do with metabolizing a lot of their medications, but specifically, we talked about 3A4, tamoxifen has to be metabolized into endoxifen. Okay, so 3A4 first, then 2D6. So when all of our oncologists are giving people breast cancer with tamoxifen, it's not 100% of the blockage, and I didn't point it out when we looked at the receptor affinities, but it has a really low receptor affinity. Unless it's converted to endoxifen, you're not going to get the effectiveness of the drug. So poor metabolizers, you can see, might be by ethnic, but if it's a rapid metabolizer, and it's going here, that's not necessarily bad, but we worry about these poor metabolizers. Thyroid hormones are really important too. This conversion of T4 to T3 I deal with all the time. There are so many things that affect this enzyme. The level of cortisol, is it too high or too low? The level of vitamin D, the level of iron is important. Other cofactors like selenium, zinc, they're listed here. These are things that help with conversion. So I thought it was really cool that we got this on the report about a mild reduction so people would know. And here's a list of low thyroid symptoms. Sex hormone binding globulin is another really big one that I look at because it does affect what's available. If you have bound hormones, it's like taking it out of your paycheck and putting it in your 401k. You have that, but you can't access it. So the CYP17A1 is important for converting cholesterol and pregnenolone into DHEA. So if you have an increase of that, remember if it's an upregulation, that may be an issue. Or if you have mild increased sex hormone binding globulin, you may have less free available to work. So this is the hormone chart again of the new report. And you can see that they break down the enzymes and metabolites into protective. So we talked about this 1B1 most normally being red. If you have a COMT, a slow COMT, that's a problem. These are harmful metabolites. You've got the 3A4, you've got the aromatase, you've got the 5-alpha reductase, which is really important for acne and testosterone. And then we've got, that's the same thing for progesterone and pregnenolone. So that's a 5-alpha preference. So it's good to know what's your hormone doing. If you're giving someone testosterone, you want to know, are they likely to turn it into dihydrotestosterone, which is good in some ways for women, for their libido, their hair. They don't want to have acne, but or are they turning into estradiol? So genomics can help this as well to look at that. And then you'll get this chart about aromatase. You may have a slight increase in estrogen from conversion. Here's your 5-alpha reductase, which is involved in turning to dihydrotestosterone. That's important. We talked about the 1A1, we talked about the 1B1 and the 3A4. So this is all super helpful, and to spell it out like this for practitioners, I think is also really great to help you actually kind of reassess that. Now, this is a copy of what it would look like to do a urine test. So this is not a genetic test. This is a urine metabolite. So one of the issues with this, you get this methylation index. So you may know that your patient has a slow methylation, but they might come up as high. So it might be confusing. But keep in mind, this is the 2-hydroxy and the 2-methoxy. It's much, much harder to methylate the 4-methoxy, and that's not on this report. So if you see someone, you're like, that's weird. Why do they have high methylation activity, but I know they have a slow COMT. What's going on? Now, again, here, maybe they have an increase in their 3A4, which is the blue. And then here's that 5-alpha reductase that we were talking about with progesterone here and with dihydrotestosterone. So these are the actual levels of the metabolites. Wonder what's going on with this person. See how low her testosterone is? Is she shunting it to estrogen? You don't see high testosterone metabolites, so you wonder, does she have an aromatase SNP? And we also want to know what's going on. Does she have a 3A4 SNP that she's upregulated? So here's where you can put together the pieces. A lot of times, I just had a webinar last night or earlier this week that I was doing that someone said, if we get high levels on this, is it the dose or is it the detoxification? So that's why having the genomics, I think, is really helpful as a piece to determine, is it the dose or the detoxification or the genomics? This is another version of another urine metabolite test. And so this is the Vibrant test. And you do get a pathway here. This patient probably has a 1B1 SNP because look at the high percentage of the red. This is 1B1 here. So we see that she's got kind of low levels of the 16-hydroxy. So she's got maybe a slow, and a 1A1, she's got okay, but a little low. This is the type of person that would benefit from DIM. And so we know she has a 1B1 SNP, and we know she possibly has some 2-hydroxy issues also. The neurotransmitter part, I think, is really helpful because I see a lot of people with mental issues and mental health, just anxiety, depression, maybe not serious, but enough that it's bothersome to the patient. So I love that it has the COMT SNP. We look at it for estrogen detoxification, but it's also important for neurotransmitters, okay? So we can look at, here's the assessment. There are tests that you can actually test neurotransmitters, and so that may be helpful. Excuse me. But we've got the MAOB, we've got the COMT on this report, and the dopamine receptor also. So that is really helpful in my book to look at it because hormones and moods, they always go hand in hand. So you want to know, is it the hormones, is it the neurotransmitters? And then I love this part of it because I've just started using a lot more oxytocin in my practice. So this is oxytocin, mild reduced oxytocin function. So we use oxytocin for low libido. Patients who have PTSD and high cortisol will often suppress their oxytocin. We give it intranasally. So this would be good to know. you have mildly reduced oxytocin receptor function. And think about having it, someone who is going to go into labor. It'd be nice to know that they're sensitive to it. BDNF is something really important, brain-derived neurotrophic factor. We look at this, you can increase this from exercise. It's important for mood. So again, although it's not specifically hormones, I wanted to highlight this part of the test because I would use it clinically a lot. And then the detox SNPs, glutathione. Like I mentioned, that's the third phase. So these are some of the SNPs that you might have, and they're sometimes reported as present or absent rather than heterozygote, homozygote. So this says normal, you have trouble, this is superoxide dismutase, glutathione. So super important for estrogen detoxification also because it's like the backdoor genomics for that and detoxification. So this is a marker of organic acids that you might see from the dried urine test, and we actually get a marker of pyroglutamate. So having these SNPs side by side, it's helpful. Mild decrease in glutathione, mild decrease in oxidative stress. There's actually a marker here I didn't put on this slide that is oxidative stress marker. It's an 8-OHDG. So see how this GSTM1 is a deletion. So it's present or absent. Okay, and then these are variants, GSTP1. So if you knew that you had problems making glutathione, you might actually take some NAC. And so I know I have some glutathione SNPs, and so I'm flying, a longer flight across the country next week. So I'm going to get an IV and get some glutathione pushed in my IV before I go, because I know I guess you need to detox from flying on long flights. It's not that long a flight, but if it's 4 hours or whatever, I usually try to get some glutathione. So that is actually the end of my slides. And so I am open to have any questions that you guys have. I just wanted to take a few minutes to kind of talk through what I see as important when we're evaluating our hormone patients. I mean, there's so much more on the report that I didn't include in the slides as far as exercise. I mean, all women with hormones, a lot of them are going to have struggles with their weight. So you get information about exercise tolerance, likely to regain weight. So that's also another really helpful part of the report. But I'm open to any questions that anybody has about anything that we talked about today or really anything hormonally. Okay, so the first question is, what impact do methylation SNPs have on hormone clearance and estrogen dominance? So I do know there is some peripheral, even though MTHFR is not directly related to estrogen detoxification technically, because it's in that cogwheel of running adjacent to the neurotransmitter cycle, which obviously feeds into COMT, which is phase 2. Those are really important. So although genetics, it's like genetics loads the gun and epigenetics fires it, right? I think I'm saying the saying right. So if you know that you have a slow COMT, you're going to do the things that are going to help that COMT. You might take some supplements that are going to augment that activity, or you might know in your dosing protocols that somebody needs a drug holiday because they tend to accumulate estrogen. So we can pulse estrogen dosing. So those SNPs have a direct correlation, more the detox SNPs, like I mentioned, the CYP1A1, 1B1, 3A4, and COMT. MTHFR has a peripheral assessment too, so I do see that it does involve and seem to affect hormone levels, but not quite as much as COMT. And then having those extra glutathione SNPs on there are extremely helpful because that's the back door. If your COMT is slow, you still got another chance to get things out of there with that Roomba, and then looking at that methylation chart as well as the detoxification. All right. How do genetic mutations influence hormone metabolism and balance? And so remember too that if you think of DNA as a double helix, right? Like a ladder. We got a double, two strands of RNA, and then you've got the alleles. It's going to be adenosine, thymine, cytosine, guanine, and those are going to come together in the middle. One SNP is a single nucleotide polymorphism. So within that 1A1 gene or even the COMT gene, there are many alleles that are making up those rungs of the ladder, right? So V158M is one allele, H62H one allele. So if it's heterozygote and you're climbing up a ladder and there's one rung that's broken, you might just be able to skip over that and keep going. It may not have a consequential effect on you depending on what else is going on. Are you eating clean? Are you reducing your exposures to pesticides? Do you have an overwhelming toxic burden? Is your liver functioning well? Do you have anything else that's going to affect your liver? Are you drinking too much alcohol? So you might have a genetic mutation of COMT, and if you're doing everything great, then it might not have a consequence to hormone metabolism. That's why I think if you just have one set of information but not the other, if you have the genomics but you don't have the urine metabolites, or if you have the urine metabolites and you don't have the genomics, I think you're guessing a little bit about things. So I think it's extremely helpful for my patients to have both if they're able. And these genetic mutations, it's not an end all be all. And some mutations are stronger than others, like that aromatase SNP, I think, is more consequential than the 1B1 potentially. And the glutathione SNPs too are really important as well. So I think they're all important. It's not one SNP that really, like this MTHFR, when people come in and say, I have MTHFR, okay, that's one of many. As I showed you, the whole methylation cascade, there's so many things that goes into it. So we try not to get fixated on, oh my gosh, I have this SNP, I have this SNP, I have this SNP, because it's one of many alleles. You still have a functioning, and then it depends, is it in the coding gene or the non-coding gene of the protein? So is it really going to affect translation and transcription of that protein? Maybe not. So there could be, when you're feeding things through from, say, 23andMe, you're getting like 10 MTHFR alleles, which some of them are not significant. So patients are like, oh my gosh, I have MTHFR, which maybe it's an allele that has no clinical significance. So that's why doing a targeted test like this and making sure that all the SNPs have the right data behind them, that is something that's really helpful for our patients. Okay, how would you approach conflicting SNPs, for example, fast versus slow metabolizers regarding hormone imbalance? So that's another great question. And so I see it also as a piece of the puzzle. And so if you know that you have a fast 1B1 and a slow COMT, we're really going to watch your estrogen levels. We're really going to look at your estrogen metabolites. If you have no problems with estrogen detoxification and no SNPs that are concerning, it's going to definitely help us with your dosing. So when I know that people have SNPs, especially the COMT SNP, that affects their moods, their ability to maybe tolerate B vitamins. So it's really important to have that information. What we do is we try to explain this to our patients. And again, they want to get fixated on, oh my gosh, I have this SNP, I have this SNP. And we tell them, again, this is just a highway. You have 2 lanes instead of 4 lanes. You could still have no traffic at all at 1 p.m. if you're trying to get downtown, but if you're trying to go at 7 a.m., you know, when you have this stress level, when you have these issues, maybe you should, like I said, take some extra glutathione. So these SNPs are really helpful to make lifestyle recommendations if you're in the business of prevention. Okay, how do COMT and MAO variants affect mood symptoms? This is a huge one. So COMT is one of the ones that sometimes I see. Now, if you look at the data for integrative psychology, psychiatry. They'll tell you the biggest predictor of depression, suicide ideation, anxiety is adverse childhood events, right? It's 10 questions. If you're not familiar with it, it's 10 questions that have you been abandoned? Have you been ridiculed? Have you been abused? Have you felt secure? 10 questions, and a score of 4 or higher puts you at a higher risk of depression or suicide or anxiety. Okay. But I see patients that have a nice home, no adverse childhood events, loving parents, and they hit puberty and they get this anxiety, terrible, debilitating anxiety. And that's when I see slow COMT. Because if you think about it, you've got a highway. Let's just say you've got 4 lanes and now it's 2 lanes. And your dopamine and your norepinephrine are a little slow, but it's fine. But now all of a sudden you got to share this highway with estrogen when puberty starts. This is why you get a backup, no, not only of estrogen, but you get a backup of dopamine and you get a backup of norepinephrine, which can contribute to your mood symptoms. So I think that is really important. Now, MAO is a teeter-totter between dopamine and serotonin. So if you have a slow MAO and you're not getting rid of dopamine that way, or serotonin, if one's going to be higher or another, it's going to shift that enzyme. So serotonin. Now, again, if you look at the literature, they'll tell you, oh, neurotransmitters don't have anything to do with mood. It's like, again, adverse childhood event. It's situational. It's family of origin. It's whatever. But I do see a lot of patients that this is exactly the cause of their mood shifts is their genomics. And we try to take that information and balance their hormones and give them some support. We use a lot of magnesium, B vitamins, sometimes SAMe for COMT. We know they can't always tolerate B vitamins. So there's some supplements called B minus that I like. Dr. Ben Lynch, if you haven't read his stuff, he has a lot of stuff on methylation. So those variants are really important regarding mood symptoms. And so I do like to do the genomics on young girls that come in teens with anxiety or new onset panic attacks. I like to do this test to kind of figure out what neurotransmitter SNPs they have. Okay, how do you integrate genetic testing for PMS, PCOS, or perimenopausal concerns? Great question. So there is no genetic component that has been isolated for PCOS as a causative factor. Obviously, everyone goes through perimenopause, and PMS, the definition seems to be more a diagnosis of symptoms rather than a root cause. And women seem to be more sensitive to the change in estrogen and progesterone. So it's not necessarily, it could be a low progesterone, it could be estrogen dominance, or it could be the drop in estrogen and progesterone that happens right before the period. So I think that for people looking at the genomic testing and how they manage their neurotransmitters, really important for their mood, if it's a PMS thing. For a PCOS thing, their body doesn't ovulate naturally, so they become estrogen dominant because they're stuck in the follicular phase. So they naturally are estrogen dominant. So if you add slow estrogen metabolism on top of that because of SNPs, it's going to make it worse. So it's good to know how they are. And especially for perimenopause, the same thing. A lot of women in perimenopause, because progesterone drops after 40, become estrogen dominant. And knowing how their detoxification SNPs are and also their estrogen metabolites helps us navigate the symptoms. Perimenopause is a time that they can have drastically oscillating levels of estrogen. And that's very dangerous to the breast and the uterus. And that's when we see an uptick in breast cancer incidence. And that's when we started hearing about endometrial hyperplasia and uterine cancer as well. So having the genomics coupled with the estrogen metabolites in some of these clinical situations can be very helpful. All great questions.
Tara, thank you so much for sharing your expertise with us. So many real takeaways about hormones, genomics, and navigating women's health with confidence. And thank you to everyone who joined us live or on replay. We hope you're walking away feeling more empowered and informed. If you want to connect or learn more, be sure to check out all of Tara's channels, the Hormone Guru MD. And if you're ready to take your wellness journey a step further, check us out at MaxGen Labs. Until next time, stay curious, stay well, and we'll see you soon. Thank you again, Tara.